I'm very pleased to have John Brownstein, Chief Innovation Officer of Boston Children's, speak here today. I'm Paul Varghese. I'm the clinical lead for health informatics for Verily. And I'm going to give you a brief introduction to Dr. Brownstein. He's a computational epidemiologist trained at Yale University. He's also professor of medicine at Harvard Medical School, author of over 200 scientific articles. And in 2015, he became the Chief Innovation Officer at Boston Children's Hospital, where he leads a team of 40 clinicians, software engineers, product managers, et cetera, where they actually push the envelope on how technology is used in healthcare. I first met John when I was a biomedical informatics fellow at Harvard Medical School, and we invited him to give us a talk that we still speak about today. And that's because these were some of the topics and terms that John talked to us about his research. So yes, he talked about using geostationary satellites to use image recognition to evaluate how well Ebola quarantines were done. He also talked about investigating crowdsourcing of black market drug prices using dark web and Silk Road. And it included what I feel is the single best combination of strange abbreviations: the World Health Organization, WHO, DEA, Drug Enforcement Agency, FDA, Food and Drug Administration, my personal favorite, FML, which I'm not going to explain. But John has been a colleague and mentor of mine, and we were so impressed with his work. As fellows, we were not the only ones who were interested in talking to John. This is an article about John from CNBC. When big tech companies want to get in health, they call this Harvard researcher. And so Google did too. This is back in 2015, and when Google Flu Trends needed to be handed over to somebody who could extend the work, that's John and his team. Uber is working with John. He'll talk a little bit about his work with non-emergent medical transport, but maybe John can tell us a little bit about how this happened. I heard it involved a text to Uber about suggesting they get into healthcare. John is also known as one of the people who has popularized the notion of the digital phenotype. With the ubiquity of technology in our lives today, we can leave a lot of clues about our health state in the interactions that we have with the internet, social media, et cetera. And John has been on the forefront of how we can harness what we consider non-traditional healthcare information to get a better understanding of a patient's state of health or disease. John is always really good at predicting where the puck's going to be, and I can say that because he's from Montreal, so he knows hockey. John is on the forefront of how do we use other forms of technology to advance healthcare, and that includes voice activation of applications in health. And that's the build-up for John's talk, which is digital phenotyping in the future of healthcare. Please welcome John Brownstein.
Thanks so much. Thanks. All right, great. Thanks, Paul. Very nice introduction. Really appreciate it. It's great to be here. In many ways, Google's been a sort of a connection and collaborator since I started in research in the Boston area about 15 years ago. Been actually intersecting with Google sort of in all parts, actually, and I'll be giving you a bunch of examples of how we've worked together. And so many of the concepts are not super foreign to this group because much of it is drawn from sort of insights that you've been collecting throughout the years and ideas that have been driven through the understanding of how consumer tech is changing the landscape of healthcare. And that's been really the thesis of the work that I've been involved in, is well, what is changing on the consumer landscape? How do we start to bring some of that technology to understand the health of populations, improve access to care, and understand disease outcomes, and this concept of the digital phenotype, which is this idea that all the data that we generate in our day-to-day lives actually can provide meaningful information about us and collectively about populations. And so I'll give you a level setting of why we started looking at non-traditional data sets. So this is a graph of myocardial infarctions, heart attacks across the partner's healthcare system. That's actually not a count, it's a cumulative sum. But what we noticed over a 10-year period is we saw this massive increase in heart attacks emerging in the early 2000s. And what's interesting, and it doesn't prove causality necessarily, but we had the introduction of Vioxx right around that time that we started seeing that increase. That increase went away with the withdrawal of that drug. And we did much validation off of this through medical records and showed that there was really a connectivity between that increase of expected heart attacks across the partner system and the prescription of this medication. And we weren't looking at this prospectively. This was all retrospective data. But it tells us that there's all this mass amount of healthcare data that's being collected that we're not using in any real appropriate way to inform our decisions. And there's a lot of reasons for that, and mostly because data is siloed, people own it, they don't sort of share it in ways to sort of optimize the care of their health, of their populations, and more broadly in public health. At the same time, we know that we're generating huge amounts of data across all sort of aspects of the patient, whether it's their phenotype data, their genotype data, across their interactions with health systems. There's all this information that's being generated, but not really used in any way that is valuable for the patient, or at least not optimized for that patient. We often turn to geographic information systems. I mean, obviously, the inventors of the Google map, of course, there's a deep understanding of the fact that data layers are connected by their latitude and longitude, and we create a very comprehensive picture of a physical area based on that interaction between lat and long. Similarly, and this is what we're trying to do at Harvard, and many groups are doing across the world now, is thinking about trying to organize patient data across sort of that identifier to get all those layers of information to get the most insight we can, and of course do that across populations to get new insights. So that's really the ideal state of the world, but of course it's really challenging again because of these siloed sets of data that exist, and again, many of the groups here are thinking about how to unlock the potential of these data sets. At the same time, and Paul mentioned that I took over as Chief Innovation Officer at Boston Children's, we're really thinking about how to better use the data that we have about patients to help make better informed decisions. And it's always funny to talk to an audience like this that understands the idea of using data to drive decisions. We do this, and you do this across all the products that you have in news and entertainment and travel. But that just doesn't exist in healthcare because of the reasons, because of lack of data, because of lack of an ecosystem that's leveraging that information to help around decisions. And again, that has changed. But if you look at other industries, and it's funny, again, to bring this up to you, but of course, the industries that have now been displaced by new companies, of course, are the ones that are thinking about how to better use data about individuals and collectively make better assessments to then provide better feedback and better decisions. So super clear to you in this room, not necessarily super obvious to healthcare, and it's been really beating this drum for many years to understand how to make this work in a healthcare setting. So one clear example, I can go onto my app on my phone and see the current temperature, see what the forecast looks like. And that's done because very clearly there are massive data sets being made available by organizations like NOAA that make large data sets available in real time via API. If you start to think about why this doesn't exist in healthcare, it's super clear. There is no underlying data set, there's no API, and there's therefore no ecosystem of applications that lets you understand what's happening at the individual level or across populations. So we've been trying to solve for this issue for a number of years, and in fact have been working with Google for many years to think about how to solve for that. The first project that we did in this space was actually started well over 10 years ago, called Health Map. And we had this idea that just as Google mashups were becoming something that people were turning to, why couldn't you go to a map and understand what was happening with the health of populations? And specifically, my background is in infectious disease, so why couldn't you go and see what outbreaks are happening, where the risks to populations exist around the world? And in fact, actually wrote an email to what was google.org at the time and said, listen, you can start to scrape the web and get insights just by mining news and social media and blogs and chat rooms. All of a sudden now you can paint a picture in real time of what's happening around the world in ways that you couldn't if you just went to the WHO website, which maybe posts a couple dozen outbreaks a year on their website. It doesn't give you this comprehensive view of every disease event that an individual might be worried about, or a clinician should know about in the care of a patient, or actually a Ministry of Health to understand what's happening even in their own country or maybe in adjacent bordering countries. So my first grant actually ever was actually out of google.org, where we started building this technology to the point where now this is not only sort of an add-on or something people think about, but it's core data now that's feeding many organizations' intelligence gathering operations ranging from CDC to WHO. now we're in the non-traditional data sets. Like, how could you think about news or social media as being a valuable healthcare data set? Well, the first signs of H1N1, if you guys remember swine flu, didn't come from a report coming out of the Ministry of Health or from CDC. It came out of a news site talking about a mysterious illness in Veracruz, Mexico, about a town that had over 50% illness of flu-like symptoms. That was the first sign of H1N1, but more importantly, this idea that you could start mining the web for all these breadcrumbs of data, both at the population and individual level, meant that you could actually track a virus as it moved around the world in real time. And that's not something that had ever been done before, just based on the fact that you could just mine all this existing free data. This wasn't information that was held on by any particular government. This was data that was out there, but just hadn't been processed, hadn't been tagged, there was no NLP or machine learning tools to organize that content. Once you could do that, and then all of a sudden now you have insights that were never made available before. If you fast forward now to, for instance, the emergence of Ebola that happened a few years ago, we have this idea now that there's actually, you could start mining even in resource-poor settings from sources of physicians on the ground, NGOs, other organizations, in a way that you could start to actually build real-time view at a local level of what was taking place with this really, massively important outbreak. But beyond that, you can start to integrate other data sources. So for instance, transportation network data. So I want to layer in the movements of individuals via passenger itinerary data. All of a sudden, now you can look at the risk of introduction of this virus, Ebola virus, just by integrating that data set. Similarly, with the emergence of Zika, people are familiar with that. Zika emerged also across a huge geography. You could never tie any particular government's data to understanding that vast movement. This is from the mining of all this underlying data from Twitter and other sources where people were confirming cases as they emerged. So this concept of mining all this information has, of course, evolved over time. It initially started with this idea that you could just sort of scrape the web and news and blog, but it became much more individual as sort of the advent of social media occurred. The idea that what one likes on Facebook or when somebody tweets about, someone searches about, that becomes much more valuable information than just, say, someone posting a news article. And so our view of this idea of this sort of digital exhaust was that if you could start to build algorithms that identified health-related topics in these sites and then started doing that across multiple individuals, all of a sudden now you have not just mentions of events in a population, but you have actually insights to people's phenotypes as they interact with the web. And I'll give you some examples for that. Google Flu Trends, Paul mentioned Google Flu Trends. I was actually actively involved in the initial concept, and so there's controversy around the platform itself, but the reality is it was really transformational. It really opened people's eyes to the concept of a search query being something and a reflection of someone's health status. And yes, it had challenges because the models weren't being reevaluated over time as people's search behaviors changed, but the concept is still incredibly valuable, and in fact, it really created a whole new field of study in the use of search query data for purposes of health. And there are many, many examples of how query data has had an impact, and we're still working with Google right now. This is work with Google X on some work around foodborne illness post-Hurricane Harvey, where we're using specific search terms around gastrointestinal disease to track where we might see the emergence of outbreaks, of course, following the hurricane. Google, of course, not being the only place where you can get digital phenotype data. Yelp, you probably didn't know 10% of all Yelp reviews are food poisoning related. So we can start to scrape every Yelp review and start to get really interesting insights. This is from a particular area around San Francisco where we actually identified particular restaurants. And in fact, I started to identify ingredients that people were reflecting in their illness. And we did this on a national scale, of course. And then what we found was, whereas people might think the consumer isn't smart enough to understand what's sort of driving their illness, in fact, the ways in which consumers talk about the ingredients actually reflects almost perfectly well with what CDC reflects in their sort of the source of every foodborne outbreak as well. So a lot of really incredible, valuable information to the point where we actually worked with Twitter to start to mine anytime someone mentions diarrhea. And you might be surprised that millions of people tweet about their own diarrhea on Twitter every year. And so we said, OK, well, if that's a source of data, we'll grab it. And so what we ended up doing was creating an auto, sort of essentially a mining of any time mention of a certain set of symptoms. And then we have an auto response that allows, say, a public health department to respond back to a consumer and get a customized survey to collect much more data. And our view of this is public health should be just similar to like United Airlines, reflecting back. Someone has a complaint, public health can be there to respond to it. And so we've been building these tools for public health agencies to really get back in the game, and we say putting the public back in public health. There are many other areas that you can start to think about. It's not just about infectious disease. Paul again mentioned the idea of the FDA. And absolutely, when we think about the events that the FDA sees in terms of adverse drug events, it's a very small window into what's actually going on with individuals that are experiencing issues with the medications that they're taking. We get a very biased sample. Of course, most of it all comes from pharma and life science companies, but we know that there's a much bigger opportunity understanding what's actually happening in the real world. And we also know that patients aren't obviously that super active, and even if they knew that they were experiencing an adverse event, they don't remember or they don't think to report that to the physician, and the physician knows about it, they don't usually report it to the FDA. So our view is, well, why not just go to where patients are already talking about these issues and think about how to amplify the voices. And so we built the FDA social media mining tool, this idea that we could start just going to the patient voice directly, get insights about adverse drug events, and start to provide important signals to both the FDA and to pharma companies. So again, this is this idea of like, how do you take the way people talk about their interactions with medications and make it valuable from an FDA and a regulatory perspective? So you have to identify a drug, a reporter, a patient, an outcome, and all of these things are actually identifiable even from something as short as a tweet or a Facebook post. And so all of that work can be done. I think the most challenging one, of course, is how do you identify people's outcomes when there are many ways in which people talk about the outcomes they experience online. And there's a whole effort, and this is painstaking for years and years of work on the human tagging side, and we could debate whether this needs to be supervised classification or unsupervised. We believe supervised does a much better job in the end, even though it's a huge amount of work. There's all sorts of things that we have to solve for. Typos, which are kind of obvious, but then the implied phrases, like these are not things that are super obvious when we're starting to mine this, but these have to be tagged. And then invented words and hashtags and all these other ways in which people talk on the internet are not things that you would ever see in an electronic medical record, so it requires a whole new set of analyses. And of course, spelling variations. I'm Canadian, so we use the U. But again, the idea is that we start to organize all these mentions, and then we start to combine them with more traditional classifications like SNOMED and MEDRA. Now all of a sudden, when we're processing things like social media posts, we have an ability to tag the outcome and start to aggregate this across large categories. There are many other ways in which we can start to use these data sets, this digital phenotype data. We've done this a lot in the chronic disease space, sleep deprivation being a big topic. When you go to your physician on an annual basis, they may ask you how you sleep. You're going to think about the past night, and if you slept okay, then you just won't really talk about an issue. People won't really do a lot of sleep tracking, although there's some interesting products now out there on the market. But we thought to ourselves, well, why not just mine when people talking about sleep issues online? And there's actually a huge amount of data of people just disclosing the fact that they've had a bad sleep or they can't sleep. And what's amazing is you can start to track those individuals over time. So you know their online activity. You know how often they're on Twitter or on various social media sites. So you actually know the time points between interactions on social media. So you actually know if they got a good sleep or not. And then we can start to do case control studies where we look at individuals that are complaining about sleep matched to people that have not mentioned sleep. And there's some really interesting findings that you start to get. For instance, people that tend to complain about sleep have less followers, have much more negative mentions online. So all the psychosocial sort of attributes that you think about sleep deprivation all play out in the digital realm. So again, this idea of the digital phenotype sort of relating back to what's people are actually experiencing in the real world. We're spending a lot of time thinking about crowdsourcing and ways in which we directly engage people. there's advantages to thinking about how to sort of create participatory surveillance systems. So it's not this idea of just scraping people's underlying data, but how do you actively engage people directly in surveillance projects. And I know there's been some really exciting work with Verily and the Baseline project. And so this is maybe more of a surveillance effort, but it's similar in the sense of if you could start to build an incredible sort of cohort of individuals reporting information, you can get insights that would be very challenging otherwise. And so this was actually also initially funded out of Google, Flew Near You, this idea that we could start asking directly people how they're feeling. And if we can get insights about symptoms people are experiencing, we can combine those symptoms to understand flu in the population, because there's a specific definition for flu. And so what's amazing is just building a system like this, you can get 100,000 people just reporting on a weekly basis, telling us how they're feeling, how their family members are feeling, and also their vaccination status. And so at that point, you get some really interesting insights. You can understand flu in a population or at the national scale, which is all well and good, but you can get other data sets. You can understand sort of the demographic and age distributions and very granular geographic data. And more importantly, you can get vaccination status, so you have understanding of efficacy of the vaccine very early on in the season. And running a system like this really is fractional compared to what it takes to run a true surveillance system at the CDC, where you're engaging with physician offices and laboratory facilities. This is all very inexpensive, and the amount of data you get is pretty incredible. And the other side of it is that the individuals are being educated about the importance of immunization. And so you sort of have also this secondary benefit of tools like this, which they represent public health education. So we're thinking about how do you start to extend that, because it's very hard to get people engaged in a crowdsourcing tool, to keep people engaged on a weekly basis, even if it only takes a few seconds. So we've been building tools out of Boston Children's to think about, well, what do people really want? Well, when I have a 103.4, I don't really know what that means. I have a set of symptoms. What should I do? Should I race into urgent care? Should I go to the ED? Should I self-treat? But we have all these guidelines, but they're in binders across the hospital, and people, when they come to the ED, there's some guidelines that exist, but people don't have those guidelines easily available to them on the web. They may go to a WebMD where there's no sort of decision support that's customized to you as an individual. There's very sort of generalized guidelines that probably all end up in cancer anyways. And so you want to think about where there'd be opportunities to customize this kind of information. We built this tool that allows parents and individuals to understand what to do next, what dosing they need to do. But again, in the back end, we're collecting all this incredible granular geographic data about health status that can help feed our surveillance of influenza. By extension, then, we have these decision support tools. These can then connect via API to a whole new sort of ecosystem of technologies that are out there in the connected device space. And my bias is in the influenza and infectious disease realm, but you can think about this in many other domains in connected devices, where you have a Fitbit or any other device that you get some form of metric out of, but there's not a lot of context to what that means in a clinical setting. And so with a connected thermometer, what we've done, and this is one out of Withings, that essentially, or now Nokia, I think, but the idea is that you take a temperature, and then that feeds you into their app that is connected via API to Thermia, which is our tool, and then you go through decision support that then tells a parent what to do with their child with the certain set of conditions that they have. So all of a sudden now, it's a much more sort of personalized view back to that individual. And we've been doing this across the whole sort of platform of applications in temperature sensing, one-off temperature sensing, continuous temperature sensing tools. That all of a sudden becomes incredible data back into the system, but again, provides better information back to the individual. And there's no, it's always, on one hand, good to talk to this audience about sort of next generation technologies. On the other hand, I need to be careful, because you, I'm sure, know a lot more than I do in this space. But we've been thinking about all the new technologies and tools that are going to be out there for the consumer going forward. And it's important for us to stay on top of it as a healthcare system, and trying to understand better ways to interact with patients, better ways to collect data about outcomes. And so, of course, all the new conversational interfaces that are emerging are ones that we think are going to play incredible roles in interaction with patients. It could be, of course, in ways in which it's more administrative, like how do I book an appointment? with my healthcare provider, or it could be much more educational, like I'm experiencing these set of things, what do I do next? And so we've been thinking about, and we've built some tools in-house. We've also partnered, this is a company that spun out actually out of Harvard Medical School, and that I personally have been part of, but also Children's is a part of. This is Buoy. There's several other companies in this space, and this is the idea of taking underlying medical knowledge, pulling it together in a way that you have now a conversational interface where the questions that come are not predetermined, they're based on your previous responses. And the idea is that you get some sort of response back as an individual what to do next. So you're not interacting with an individual, it's just purely a chatbot online. But what we've seen when we've started to do this at Children's is that there's incredible value to be gained from it. Already in very early stages, these algorithms show incredible diagnostic and triage accuracy. Triage accuracy being the most important. For us, we get inundated in the emergency department with acute conditions that probably could have been treated at home. And so these AI-based tools at the front line can be incredibly valuable in helping divert people to the right care, whether it's stay at home, go to urgent care, ED, wait to call your physician. Again, now we have these sort of first level tools that can help, especially in locations that are resource poor. Paul mentioned voice, and yes, there's probably diverging opinions here about is it a gimmick? Is it really going to be transformational? At least at Boston Children's, we've been really thinking that voice is going to be sort of the next wave of the internet, whereas patient portals were 20 years ago, and we're thinking mobile apps. We've been developing those for a number of years. The idea that voice-based tools are going to play an important role in healthcare is one that we're spending a lot of time thinking about. There's all the data that's out there about how voice searches are going to be ubiquitous, that smart speakers are really already out there. I mean, we're not talking 10 years out, many households now, a huge proportion of them have these listening devices in the home. And so our perspective has been, well, if you have a device that's continuously listening, and I know there's going to be varying opinions about how valuable these things are, it should be armed with medical knowledge. There's no reason why you can't ask questions that relate to your healthcare personally or general questions. And so we've been experimenting with this pretty broadly at the hospital, thinking about the applications in the home, applications within the hospital, and then, of course, in the outpatient setting. I'll just give you a few examples. The idea is that, of course, in the home, there's all ways that you can ask about, we've been thinking about how to ask about symptoms and other things, but why not access your medical records or other types of information? Or, of course, people are thinking about this in terms of medication reminders and other types of tracking tools. In the inpatient setting, of course, there's all sorts of ways in which we're actually already experimenting with this in the hospital. So the idea that a physician who needs to be hands-free can access all the medical knowledge of protocols, the ability to page people, huge amount of things that need to be done in a fast-paced environment where voice is heavily primed for. And then the outpatient setting, and this is one I think where probably is the most conversation that's taking place. Why not have sort of a digital-enabled listening device as part of the interaction that a physician has with their patient that brings all that conversation together, codes it up, and then, of course, brings it into the electronic medical record, improves the interaction with the physician and the patient, but at the same time, is able to reduce a huge amount of the workload that our physicians are experiencing, which is pretty unbelievable at this point. And we're not the only ones thinking about it. We've actually been, we just published a paper thinking about all the broad landscape of voice-based tools. There is an incredible array of technologies, people thinking about this in the aging space, people thinking about this in the dictation space, many different domains. We're actually running a whole voice healthcare summit in October if people want to come join that. We have been working with Amazon now for several years. We built the first healthcare skill for the, Amazon Alexa called KidsMD. And essentially that's about just collectively putting together all the questions that parents have to ask about their kids. It's very early days, it's improving over time, but it was this sort of this use case, like how do you start to use Alexa in the way that it can arm it with information that's valuable to parents? It's pretty straightforward in the sense that how the skill works and how it interfaces back with our underlying system. We have a number of different tools around fever and asthma and other products. I think the holy grail, and this is where I don't have a lot of data, is more just a lot of interest, so throwing this out there in case anybody wants to work on this project. There is a huge amount of opportunity, I think, in the biomarker space. I think that if we can get over the concerns around what this means as, from a privacy perspective, The idea that your volume and rhythm and tone and all these various features of your interaction with a smart speaker, if that can be collected, those have really important insights that can be gained. Just sort of how search query data was incredibly revolutionary and still now paying dividends in terms of research, and I think the same goes for voice in the sense that there are many, and this is already published data, this is not just my prediction, there have been published studies in all of these different domains where voice is actually contributing some insight and early detection to many different diseases in many different domains. So anyways, just throwing that out there in case anybody's interested in collaboration. The last thing I'll talk about is on the healthcare delivery side and sort of the last phase of where I think consumer technology plays a role. We actually launched a product called HealthMap Vaccine Finder just maybe a couple years after the swine flu outbreak. And in fact, this is another example of us taking a product from Google. I think now this happened 3 times. So Google launched a product which is a vaccine finder tool to help people identify what vaccines to get and specifically where they can get the H1N1 flu shot after the pandemic. We ended up taking over the product and expanding it across a range of different vaccines and built a tool that essentially has now every Walgreens and CVS and Walmart and mom and pop pharmacy where we have their supply information, their pricing, location, all the data that an individual needs to make a decision on what vaccine to get and where. Despite that being super, we think, convenient, you can't walk a block without getting sort of an ad for a free flu shot. It's still challenging. So then we thought to ourselves, well, consumers are experiencing all this incredible value out of the on-demand world with Uber and Lyft, and like, why aren't patients seeing the same thing? And so our view of it was like, okay, well, why not start to think about flipping the script and getting these things to the individual? And yes, now everybody talks about Uberification of healthcare, and there are a lot of good examples of that. At the time, I couldn't get Uber's attention on this, but I actually wrote a complaint. Well, I wrote in the box where you complain about your ride, but instead of a complaint, it was like, ride was fine, but maybe you should think about healthcare. And somehow someone on the other end read that, like, okay, and then they came to visit us, and we pushed them on this idea of flu shots. And we convinced them, and you know, I know you people here understand how difficult legal is, so just think about maybe even worse, I don't know, but anyways, just getting legal to agree to putting a button on the Uber app that was about bringing needles to people wasn't like necessarily the easiest thing to convince them to do, but we did, and we've done this for several years now where we put nurses in Uber vehicles, and essentially you request a vaccine on demand. And it was pretty cool because we were able to collect a lot of survey data and show that people's decision to get a vaccine was heavily influenced by the fact that it was on demand, that on demand was a part of their decision. And in fact, many people had never gone a flu shot before, but because it was that convenient, they did it. And so, of course, we're thinking about this broadly now. Now, it's been several years since we did this. There are many companies that are thinking about logistics in healthcare. Of course, you've got to mention Amazon in the space too. We actually built a company out of Children's as well called Circulation, which essentially sits between Lyft and Uber and health systems to help manage logistics. So the idea is that it's essentially an exchange platform where our view is that patients should experience the same level of benefit as consumers do around on-demand, but the current status quo for patients who can't afford transportation is they wait hours, they have really inefficient ways of getting to their appointments. This is all covered by Medicaid and their insurers. So we essentially brought on-demand and brought it into the patient realm, and what we've seen is really incredible in that there is real huge amount of uptake, and health systems were dying for a better way to help move their patients to their appointments, but also help healthcare systems move their caregivers out to patients, help around product logistics. There are many other ways in which sort of there are inefficiencies in the health system. And so in our view, there's this whole, if you start to pull it all together, if you have these constant listening devices in the home that interact with you and that provide you guidance, that all is great, and that's your interface with the health system. And all of a sudden, you bring in the logistics side, and now you've got the full complete circle. Not only can you complete a visit and get insight, but now you can get your prescription delivered to you and get even your home care. So there's a whole new world that's emerging just from the existing, nothing incredibly innovative, just existing tools that are out there right now. Lots of challenges. I mean, we can talk about this as part of this discussion. We still struggle with this. I mean, I've benefited by having a great collaboration with Google and others over the years, but of course that is highly variable for health systems. And I think there's Google Cloud people here. The storage ideas, that still represents a real challenge. And this is like a very sort of new field of study, the digital phenotype. How do you start to process that data? How do you start to integrate that information with other sets of data? It's all super early. So we're having a lot of fun. We're kids in a candy shop because there's so much amazing data and insights to be gained. But again, how do you start taking all that insight and data and making it valuable from the perspective of clinical care? Still, I think, a little bit of a road ahead. So I'll leave it there, and maybe we'll have some discussion. Thank you so much.
Thank you, John. That was great. So I encourage people to come up to the microphones to ask questions, but I'll start off with one. I think when you're very, very close to this, you see the tremendous power of being able to gather this kind of information that is outside the traditional sphere. I mean, we know that most people don't spend their lives going to hospitals and clinics. Right. So how can we understand what's happening in their normal life? But when I have these conversations with people who aren't as close with it, they legitimately come back with like, wow, that sounds super creepy, Paul. Any thoughts on how we sort of address this notion of there's some benefit, but this can be deeply unnerving? And second, in your own experience with Boston Children's, like, have you guys thought about how you sort of bring that information in? We often think about personalized information or personalized medicine being really about genetic information or epigenetic information, but this is a different type of personalized information where is there a mechanism that I could contribute, information about my behavior, my social media activity, my physical activity back to my healthcare provider? I'm fascinated, since you're on the vanguard of this, if you have any thoughts.
Yeah, these are all questions that we get a lot, in terms of the acceptance of people. That is, when you talk to the companies or maybe at high level, people are thinking that's going to be, you're going to get a huge amount of pushback. Generally, we've done huge amounts of surveys and captured data, and generally people are very excited if the data is being used for their own personal good or to be maybe for social good. We've had a lot of success, and almost, actually, I can't remember an instance of any amount of pushback. Of course, the best policy is around patient consent. So to sort of answer your second question, there's a lot of thirst around contributing my activity data back into my system. And that very easily comes with consenting, or the data we're going to collect via Alexa. That, again, would be a consent issue, right? So I think we can already solve, even if there wasn't a concern to begin with, we can start to solve it with education and really explain to people, what they're contributing, and they have the opportunity to opt out of these kind of assessments. We're definitely spending a lot of time thinking about how to bring that data into the EMR, because again, these data are siloed. It's still a challenge. Like, frankly, getting the EMR vendors to think about this data, it's always sort of part of the roadmap, but it's not sort of clearly a big priority. So we're having to build our own applications. We, of course, been working with you for many years about using new data standards to ingest information and build new visualization tools, but it's still kind of clunky and not optimized for real clinical use just yet.
Yeah. And you described the fact that consumers have generally responded to questionnaires saying, if this is useful to me, I'm okay with sharing certain amounts of information. Our sense from the part of the business that we work in with healthcare providers is that many times the providers are so conservative, they're afraid to experiment in this area. How do you help them develop a sense of urgency around that?
We definitely have a huge variation in our physician pool around these technologies and data sets. I mean, when they're incredibly valuable and they create efficiencies, that's great, right? Like, so some of these data sets mean that can reduce the number of physical visits they need to have with a patient, right? So it reduces the amount of effort over time. That clearly is a win. I mean, we're spending, and this is not exactly like the digital phenotype data, but we're spending a lot of time implementing things like online virtual visits, the idea that you can do like a virtual interaction with your physician that cuts costs, cuts time, there's more efficiency. When physicians see that, it's a no-brainer, and I think that starts to outweigh the concerns of how valuable that interaction was versus an in-person. That's sort of what we're doing, but I think we definitely have a huge variation in acceptance.
Yeah. So follow up on that one then. Much of what you talked about was clinically oriented.
Yeah.
I think there are enormous opportunities from a business perspective in terms of how data is used and measured and analyzed. Do you get involved at all? Do you and your team get involved more on the, or at all on the business side around things like appointment scheduling, telemedicine, things
Absolutely.
like that?
So our team is focused digital across the institution. So those could be things like, clinical, like say building a precision medicine service for the hospital, but it could be just as easily like building virtual visit or online second opinion program or building our patient portal. So all the sort of more appointment scheduling, doctor finding, all those things are sort of part of the mandate of our innovation group.
Okay, last one. Are you running a business in the Children's Hospital, would you say? And how do you think about contributing to the business success of BCH in particular?
Yeah, absolutely. I mean, there's been significant investment. Obviously, I've got on my research side, research grant funding, but on the business side of the hospital, absolutely. There's a recognition that digital is going to bring costs down, right? So, and then there's also recognition that it's a must-do from a patient experience perspective. But then there's also a business side as well. The IP that we're generating and working together with companies has potential value. We also run an accelerator where we're actually spinning off companies that come from researchers and clinicians, identifying really important. And I didn't have time to go into this in the talk. There's a whole other version of this talk that is really about the accelerator and all the various companies that we're forming out of the hospital. And that's a whole, there's a business as well as mission case to doing that. We have incredible data assets. That also represents a business opportunity as well. So, both in terms of us, identifying opportunities to build things as well as partnering with outside organizations to help sort of create some sort of funding back to support these efforts.
You offered up a bunch of amazing examples of kind of infectious disease and using big data. I'm wondering if you can talk a little bit about heart disease, which continues to be the #1 killer, and anything that you're working with around heart disease and indicators. It's particularly fresh in my mind as we just launched Google Fit, which is tracking steps as well as this new, I think it's called Heart Points metric around accelerated heartbeats, et cetera. So interested in kind of what you're...
There's a project in the space I actually can't talk about now, but generally I would say that hasn't been a top priority for us because I'm in a pediatric hospital. Heart disease isn't always because we're talking about lifestyle factors. But I think more generally, I mean, the idea that we can start to bring in tools that are tracking sort of levels of activity and logging of, those things all relate, right? So we're building tools within our patient population that are sort of allowing us to sort of catalog food and other things. There's slightly differences, of course, of what things you want to track with a child, but they overlap as well. But I'm trying to think. It's very different than an infectious disease disclosure. We've done things around social media where we've looked at heart attacks related to people's disclosures of particular drugs that they've taken. Like that was a big one for us. We did this in Twitter as an example where we looked at people's medication use, and then we looked at outcomes where people reported having heart attacks, and we looked at associations. And we've done this both in social media data and clinical data sets where there's huge opportunities. But I think, but I'll have a study very soon to talk about it in this space as well. Thanks. Yeah.
John, thank you for your talk. It was really great. You touched on this a couple times about the workload that doctors undergo. I know that doctor burnout's been on the rise. I think 45% to 55% was the last stat I saw. How does your team look at like the workload of data collection that doctors have to do, sitting there typing, filling out electronic medical records? Where do you see the future of that?
I think there's some really interesting companies, startups in the space. Obviously, I'm sure that there's some groups here that are working on that. And we've cataloged this, and we do shadowing to understand sort of where the inefficiencies are. And that data side of it is really becoming such a big part of the activity that a physician has to do, which, so again, like we see it. It's the #1 complaint. Burnout is the biggest topic. It's one of our top priorities in the digital group now to solve. I spoke about voice at the end, and I think that, again, is where I do believe that there's some real opportunity in the capturing of that interaction and parsing of that. I think, obviously, the tools have to get a lot better. Nuance is an example of a company. So we implemented Dragon. If you're familiar with that software, it's just dictation tool. we've seen a tremendous uptake of that. There's so much excitement about it, and it has reduced workload. And so now the next step is, okay, well, what do we do with technology that could be sort of listening to the full interaction, to sort of go from a digital scribe to fully automated way of capturing? I think that, in my mind, is where there's a lot of excitement. The other part of it is just purely around the EMR. And I mean, again, I think this is where Google is super well positioned if you wanted to take that leap. I don't know if that's ever going to happen, but to build actually an EMR, the current ways in which the EMR is built is obviously focused around billing, not really any UI sensibility, and I think that really is a big frustration. So there's voice, but I think just generally thinking about the user interface that physicians work with. And we actually have a project right now with Verily that is trying to focus on trying to extract information and reduce the amount of work that a physician has to do to think about the sort of medical history of an individual. So hopefully we'll get to present that at some point. Yeah.
Thank you.
Thanks.
I had a question about the digital phenotyping. I thought that was just really interesting in terms of its applicability to understanding how to motivate patients, particularly motivating children and teenagers.
Yeah.
I think that's particularly challenging. So to what degree do you think you have insights on the phenotyping side into how we deliver our care in a way that engages those patients? And as a sub-question to that also, particularly in the mental health space.
Right. No, I mean, I think that there has been a lot of work, really interesting startups in the space that have thought about how to collect that data on the back end and understand important changes, right? Changes in sentiment and changes in the ways that people are interacting with technology to create some form of alerting. And I do think, well, we haven't done that ourselves. There's some great opportunities around automatic feedback loops that go back to patients around sort of questions. So the algorithm detects a real change in behavior, and that goes back to the individual and sort of asks a series of questions to get a little bit deeper. And I do think that there's opportunities to do this off of the existing platform. So you mentioned teenagers. I mean, this is where working with existing platforms becomes where I've focused a lot of my attention, rather than trying to build your own new social media tool for teens with mental health issues, which really has challenges. I mean, people have tried these things, but that's where, like, I think there's an opportunity for working with a company like, Snapchat as an example. Like, why couldn't we have some form of mechanism within those companies to work? And then that becomes challenging, right? Like I've never, as a researcher, had an ability to do reach back. Like, I've been able to collect a lot of raw data, get insights, but that loop, I think that's where this group here is much more well positioned to try and experiment with things that that the usual researcher just doesn't have.
And do you have any gamification experience?
Not so much. I mean, I'm sort of on the fence and we've done a little bit with our flu project, with trying to keep people in the system, points for the amount of reporting, people getting flu badges and things. I think they work to a certain extent, but I haven't found them to be incredibly valuable. I think there's been sort of over gamification in some ways through these tools, but we haven't spent a lot of time on that.
Well, thank you so much, John. Very much appreciate the sort of glimpse into the future, and I'd like to thank John for coming in.
Great. Thanks so much, everyone.